So good evening. My name is Nathalie Goemans.
I am a pediatric neurologist and I have been head of the Neuromuscular Reference Center for Children in the past 30 years at University Hospitals in Leuven in Belgium, and it's a great pleasure to be with you today. I've been asked to discuss the neurological management along the lifespan in Duchenne muscular dystrophy. And as you know, Duchenne is a lifelong complex disease, and care is provided, has to be provided by a multidisciplinary team of healthcare professionals. And within that team, one person has to take the coordination. And most often, this is the child neurologist or the neurologist for the adults, which is in all the cases has to be a neuromuscular specialist. But as you can see, a lot of other aspects have to be addressed in the care of these children. So what are we going to follow or to manage? And I think for this, we have to take into consideration the multifactorial dimensions of human disease as described by the World Health Organization. And so on one hand, we have the body functions, and this is the whole list of medical subspecialties that will come across the course of the disease, as you can see listed here. But there is more. There is also the aspect of ability and disability, and this more on function and activity of daily living and adaptive technology, assistive aids. But at the end, what's most important is probably health in general, participation, quality of life. And so these are aspects of recreational opportunities, psychosocial adjustment, integration, education, emotional well-being on the whole, and social life. So when a child is diagnosed, it should be taken care by a whole team, which make a lifelong commitment to help the patient and family throughout all stages of the disease. And as mentioned, is coordinated by a physician and neurologist most often. And all these different teams, also the paramedical team with physiotherapists, occupational therapists, and so on. You can see on the list all very important people in addressing all the aspects that I've mentioned in the slide before. And in this multidisciplinary care, one should not forget the communication, information, feedback with the people that are taking care and manage the child and the family at home. So like the school, the general practitioner, the home physio, and so on. So this has to be an ongoing communication centered around the patient and his family. As you may know, there have been new standards of care guidelines published for Duchenne in 2018, 3 very important manuscripts. And these care considerations were obtained by a specific technique, which is called the RAND method, which gathered the expertise of experts in the field. But we have to highlight that this is not a conventionally evidence-based way, because we do not have large-scale randomized trials involving the care of individuals with Duchenne muscular dystrophy. So this is the best we have. But on the other hand, it's not evidence-based. So taken from this publication, I have here the cartoon of the role of the neuromuscular coordinator along the different stages of the disease, as you can see. And as you can see, along all the stages of the disease, there is this leadership, the first in line medical advisor who really tries to coordinate all the care of the patients. This includes also advising on new therapies, providing family support, and so on. And as you can see, there are a number of other aspects listed that go throughout the whole course of the disease, throughout the journey of the patient. And this is kind of framework, but there are several aspects that I would like to highlight here, because we won't be able to go in detail in all the aspects. For me, as a clinician, I have several points where I think that as a coordinating physician, there is a very important role. This is in the diagnostic process. This is when we initiate and discuss corticotherapy or other disease-modifying therapies. Very important is the role in informing, discussing, advising on participation in clinical trials. finally, anticipation and accompaniment of life-changing events, very important moments in the life, such as loss of ambulation, major surgery, ventilatory support, initiation of gastric feeding, and so on. Very important moments that we have to anticipate and to go with in the journey of the patient. And finally, there is a very important role in the transition to adult care. So let's say a few words about the diagnostic process. For me, the referral of a child with a suspicion of Duchenne is really an emergency for psychological reasons. You know as well as me, there is no medical urgency, but this is such a stressful moment in life of parents with children that we should, as physicians, try to limit the time as much as possible. And finally, well, at some stage where we have to disclose as soon as possible a final diagnosis, which should include information on genetics, on the disease course, on prognosis, and on treatments. And we may need several consecutive clinics to go through all this aspect because this is a massive amount of information for the patients at the time of the diagnosis. And I'm well aware that the way how this has been done, the disclosure of the diagnosis, is so important for the further journey of the patient and his family and the parents, especially at that time, because normally the child is too young at that time to realize what's going on. And so when we disclose a diagnosis, providing psychological support, but also more general support by reassuring the parents that they are not alone, that there is a team to support, and that we are with the whole team trying to address all the aspects and the problems that they will face to the best of our capacities and knowledge. And so this includes also in the disclosure of diagnosis to detect and to inform carriers and to provide, at least for them, cardiac follow-up plan. But it's also important in the same way as we try to provide support by a whole multidisciplinary team, also to make them aware that there are support group, there are parents group, patients group, and this is another way to provide some help and support.
So another very important time point in the journey of the patient is obviously the start of glucocorticosteroid treatment. And as you know, corticosteroids slow the disease progression and the loss of motor milestones. They have been shown to prolong overall survival. But as you know, they go also alongside with a lot of significant side effects when used in a chronic way on a long-term treatment. And so when we discuss glucocorticosteroid treatment, it's important that from diagnosis already, we prepare the parents for this treatment. There are not many parents that like the idea that they will have to give every day something to the child that may have side effects. And especially at a time where they do not see that many problems in their child yet. So it really takes time, and it's very important to help the families to accept this kind of treatment. It's also important to assess the level of information of the parents about risk and the benefits of the steroids, and also to see how aware they are of prophylaxis of the steroid side effects. For instance, it's very important that families from start have healthy eating habits in order to refrain putting on weight too much for the children. So most commonly used dosages are drugs are prednisone and deflazacort, and you see the dosage here. So prednisone at 0.75 mg per kg per day and deflazacort 0.9 mg per kg per day. But we have also other schedules. So some use 10 days off, 10 days on, or corticosteroids on alternating days or on weekly high doses. And as you may know, deflazacort has been approved as a treatment for Duchenne by the FDA. And here you can see the list of the side effects of glucocorticoids. I know it's quite impressive, and that's why it's really important that the prevention and the management of side effects should be part of the standards of care. And I know that a number of these aspects will be discussed later in this meeting. I know that there are aspects on endocrinology, on the bone health, so I leave that to those that we'll discuss later. But these are very, very important aspects. When we look at the comparison in regimen on the long-term side effects, then you can see that, well, it's quite obvious. The more you take, so the higher dose, like daily doses, will show more side effects. So you see more Cushing aspect, more hyperactivity. So on almost everything, you will see more side effect if you take it daily. And this is from a large study in the UK, the North Star Clinical Network. And when we look at the side effect profile, we will see that prednisone probably will give more weight gain and more behavioral difficulties in comparison to deflazacort. However, it will give less growth delay and less cataract. Deflazacort, on the other hand, will show more growth delay. There are also recent reports that there might be a higher fracture incidence, but it's less weight gain and less behavioral difficulties. And that's also my daily experience with deflazacort. And when we look at the efficacy of prednisone versus deflazacort, then it's, well, a bit the other way around. We see a delay in the loss of ambulation compared in the deflazacort group compared to the prednisolone group. And this is also for the other motor milestones. So in efficacy, it seems that deflazacort has a better effect. And on the end, I think the whole story about corticosteroids, dosage, and schedules is that we may have guidelines, but it has always to be tailored to the patient and its family. So we know the more we give, the better effect on the muscle probably, but the more we give, the more side effects we will see. So it's really trying to find the right balance. What is acceptable, what is manageable in side effects, and what is the best we can achieve with these drugs. And again, prevention is very important, and this will be discussed later. There is just one thing I really want to stress, and this is the danger that we explain to the parents of stopping corticosteroids without notice, like stopping immediately. And as you know, they are on chronic steroids with a suppression of the hypophyseal adrenal axis. So they are like they will go in distress if they are in a higher medical or surgical stress situation. So they have to receive a replacement. And I would refer to the very nice website of the Parent Project, where this is explained in the Nikolov steroid protocol. So this is very important message to the parents as well. Don't miss your doses, and if your child can't have a dose, you should attend a physician to explain what you can do. And if your child is subject to medical or surgical stress, then you have to give stress doses or substitution. Something that has really changed our life as coordinating physician is the emergence of new therapeutic perspectives and clinical trials. And this takes really a big part of our clinics now. It's discussing the emerging therapies, discuss patient participation in clinical research trial or of investigational drugs. And the coordinating physician should help to personalize the risk-benefit analysis for each individual patient. And even more important, it's trying to manage the expectations of the patient and the family. Expectations are always high, and we have to be very clear and objective what we may expect for this particular child in the context of these trials. And again, we have to always to stress clinical trials are still trials. These are not approved drugs. These are not yet treatment. And all this discussion takes really time and are extremely important. And also for the physician, it's important to actively participate in the monitoring the safety and the efficacy of the new drugs, and also now in post-marketing setting to be alert for some symptoms or signs and to report if there is anything that's suspicious to the authorities. Finally, another important point is this transition to adulthood. And I think it's just the work of many, many years. Is you have, as a pediatric neurologist, you care for children, you care for the families of children, but together with them, you're working towards adulthood and independence from a young age. So you try to develop their personalities, their skills, to discuss what their abilities more than the disabilities at some stage. And so we really try to work for an active role in community. that's for the patient and the families and the participation in social life. For the medical aspect, it's very important to build on a good relationship and a partnership with adult neuromuscular team, neurologists, the pneumologists, cardiologists, gastroenterologists, and so on, and to develop their interest in these what were pediatric diseases. Many centers have adult neurologists have not been used to care for these patients, as this disease, as Duchenne, for instance, has always been considered a pediatric disease. So this is very important, and identifying a coordinating physician and to raise the interest for this disease is also the role of the coordinating physician. It's no way to take such good care for many, many years as in the pediatric age range, and then to have nothing once they are in adulthood. So the care and the management of Duchenne starts from diagnosis on and implies a lot of partners to provide a coordinated optimal care in all domains of the disease, to reduce the disabilities and minimize the impact on quality of life. Care and management have to be based on approved guidelines and golden standards of care, but tailored to the needs and the wishes of each individual patient and his family. The role of the neurologist is a lifelong accompaniment in all stages of disease without losing the focus, which is health, well-being, and social integration. And finally, I have been asked to discuss also shortly what we are living now, like the COVID-19 pandemic, and to see this in the context for Duchenne and Becker muscular dystrophy. And I've taken some points in our discussion that we have within the World Muscle Society. So you can find also this recommendation on the World Muscle Society website. And at the end of these couple of slides, I have also additional website where you can go for information. So far, there is no evidence that hereditary neuromuscular disorders, and in the context here, Duchenne or Becker muscular dystrophy, have a higher risk of infection by the SARS-CoV-2 virus. However, neuromuscular diseases and their treatments may influence the patient's ability to cope with infection or its systemic effects. So they will not be more easily infected, but they can react differently. So for instance, muscular weakness of the chest or the diaphragm, resulting in respiratory volumes less than 60% predicted, may cause a risk. Use of ventilation via mask or tracheotomy, weak cough, weak airway clearance due to oropharyngeal weakness, cardiac involvement are all factors that may increase the risk on how a patient will react in case of SARS-CoV-2 infection. A very important message is that patients taking corticosteroids should continue to take their treatment. There is no reason to lower or to stop the corticosteroid treatment now in this pandemic. So what can we do as a prevention? And well, most sensible thing are the general measures to avoid contamination. As we know, as are now disseminating the whole population, what we have to do. So social distancing is a minimum requirement, but we know that for high-risk individuals, self-isolation might be advisable because it's not always easy to keep this social distancing. In general, it's important to avoid large gatherings and public transport. Frequent hand washing, use of at least 60% alcohol-based hand sanitizers, and surface disinfection are crucial. Caregivers should be as much as possible in-house, but essential visiting caregivers should wear face masks and adequate protective clothes to prevent the passing on the virus. For instance, physiotherapists, but also the patients should wear face masks during the treatments, protective gloves protective clothes and gloves should be used by the physical therapist. Important is also to be prepared for eventualities like lockdown or quarantine when assistants are absent due to illness or quarantine. So it's important to have plans. What shall we do if this person is missing or if this person cannot come? So have like a proactive plan for these situations. And obviously, it's important to follow the up-to-date recommendation from the official website in each country because it changed really from one country to another. And so it's a message that we all also want to pass. There is so much on the internet, so please make sure that your site is not containing inaccuracies or disinformation. So ensure that inline information is directly sourced from official sites. And so with this COVID-19 task force of the World Muscle Society, we have also regular questionnaires to ask how are your neuromuscular patients doing, are there specific aspects that we should highlight. And so far, patients that have been contracting SARS-CoV-2, Duchenne patients or Becker patients have not been more ill than others. Personally, I don't know any that has been really seriously ill. I know there have been very few reports, but they recovered well. The risk population for the neuromuscular disorders are more like adult people with comorbidities such as diabetes and obesity, and also more specifically in the myasthenia gravis population. So really different. So far, it has done, been the neuromuscular population, Duchenne muscular dystrophy, Becker dystrophy has done well in this pandemic. Sometimes it's easier to lock down than to relax. This is really the problem. What shall we do when the rules are relaxing? And we know that there is a considerable variation in the way national restriction and the relaxation of restrictions are evolving. But however, considering some risk stratification, we can maybe make these considerations. So for people with neuromuscular disorders that are considered at low risk, so no cardiorespiratory impairment, no immunosuppression, no significant risk elevating factors and comorbidities, local and national guidance should be followed cautiously. And in-depth consultation with the neuromuscular specialist is recommended. For patients with medium risks, like mild respiratory involvement, controlled relaxation of the restrictions may be considered in discussion with the neuromuscular specialist, with appropriate caution and taking into account the local and the national recommendations. For people considered at high or very high risk, for instance, severe or unstable respiratory compromise, reliance on home ventilation, clinically relevant impairment of heart function, measures to avoid infection, including self-isolation, should remain in place. It's tough to say, but probably this is really the safest. Carers and family members who are no longer in self-isolation must continue to use masks and barriers when in contact with the persons at risk. Another important point is the decision to return to school for children and adolescents with Duchenne muscular dystrophy. And this will depend on individual factors regarding both the individual and the institution. But details such as staffing levels and hygiene protection according to national guidelines will be important. And there again, we see a significant variation internationally. And so to conclude, I've added a list of information website where you can find information on COVID-19. But as you're well aware, as we're all aware, this is really growing inside, this is changing and evolving. And the only thing I can wish is really that we get rid of this virus. So thank you very much. It was a pleasure being here, and I wish you a very successful meeting onwards now. Thank you.